First of all, I'd like to thank the organizers, especially Professor Anupam Prakash and Dr. Ashok, for this very kind invitation. The task which I have today is to talk about gut-brain axis in diabetes mellitus. I think all of us are aware of the intricate relationship between the gastrointestinal tract and our brain because of the terms like butterflies in the stomach and gut wrenching. And all of us have had these feelings. And we also know that in situations of anxiety or stress, we do feel a bit of nausea. Some people would have increased bowel frequency with onset of anxiety. And there's a feeling which is all too common, suggesting that there is an intricate relationship between the gastrointestinal tract and the brain. So we are going to talk about this bidirectional communication and the language of this communication. What are the connections? We'll talk about how these alterations in the gut-brain crosstalk result in diabetes. And then what are the therapeutic and corrective opportunities which are available or which could be available in the future. The best example where the gut-brain axis was evidenced comes from this very, very interesting story. And this was a patient, Alex Martin, who actually had an accidental gunshot injury to the abdomen, resulting in a permanent gastric fistula. And this provided the surgeon, Dr. William Beaumont, the opportunity to study gastric physiology. And what they found was that whenever there was any fear, anger, or anything which disturbed the nervous system, the gastric mucosa, which could be seen, became red and would lose its smooth and healthy appearance, suggesting that the gastrointestinal system, or in this particular case, stomach, is affected by our brain. And then, of course, we are all aware of the Pavlov's dog experiments. And although we more frequently talk about the conditioned reflex, we also know that it is all about how the secretions, the GI secretions, are produced by mere thinking or by mere awareness that food is going to be available. So how thoughts control our GI tract was evidenced through these experiments. So what is the gut-brain axis? So it's a bidirectional communication between our brain and the gastrointestinal system. And it has been used to explain the intestinal functions and even the perturbations, whether acute or chronic. And if we go to the components of the gut-brain axis, then the first, of course, is the gut-to-brain communication. And we know that there are two components to this, the intrinsic and the extrinsic pathways. As far as the intrinsic system is concerned, there is an antral nervous system, the mesenteric air box plexus, and the submucosal mesenter's plexus, which have a very intricate array of communication and using various receptors, the mechanoreceptors, the thermoreceptors, chemoreceptors. The sensory neurons sense the particular stimulus and then pass it on through the interneurons to the motor neurons, which can again help in different functions like secretion, maintenance of motility, and absorptive functions of the gastrointestinal tract. Now, importantly, it is essential to understand that enteral nervous system can actually function even in absence of the central nervous system. And then, of course, is the communication through the vagus nerve and the pelvic nerve. So vagus is still the colon and part of colon, and then it is the pelvic nerve which communicates through the dorsal root ganglia and then communicates to the CNS. And the vagus has both efferent and efferent supply. And the other, of course, the second one is the spinal pathway through various nerves from T5 to L5, which eventually land up through the prevertebral and the paravertebral ganglia into the spinal cord and then communicate to the central nervous system. So vagus, of course, apart from bidirectional communication, it also has can generate immune responses to microbial metabolites and has a well-recognized cholinergic anti-inflammatory pathway. So it has a relationship. It can pick up changes in the microbiota and also transmit inflammatory responses. Then comes central processing. So all the signals that reach the hypothalamus or the brainstem, only a part of them actually go on to, are allowed onto the cerebral cortex, and these are processed there. Now, the second component, of course, is the brain to gut axis. So in response to emotional stress, or which could be interoceptive or exteroceptive, like inflammation and infection being the interoceptive and life events being the exteroceptive stress, and these can result in a neuroendocrine response, which can, through the hypothalamic pituitary adrenal axis or through the autonomic nervous system or sensory modulation, may affect the GI system. So this completes the bidirectional loop through the hormonal, neural, and the immunological mechanisms. Now, a more important and increasingly recognized thing is the gut microbiota, which is a very important component of this entire axis. And the gut microbiota is huge. It's an organ unto itself, 1.5 kilograms of our body weight, a large number of species, most of them, 90% of them belonging to either Bacteroides or Firmicutes. And then what is also recognized that the central nervous system can alter the gut microbiota through changes in GI motility and through various neurotransmitters. What is also recognized is that the microbiota also affects brain and can, through the enterochromaffin cells, mediate responses to the CNS via the vagus nerve. And here you can see that the gut microbiota is continuously sampled through the M cells, and the antigens are presented to the dendritic cells, but there is a controlled inflammation. Part of it is also because of the dietary fiber, which promotes certain type of microbiota, formation of short chain fatty acids, and these result in a regulatory response. But in conditions of dysbiosis or pathogenic organisms, there may be an uncontrolled immune response through secretion of various cytokines, and this can, impact the vagus nerve endings or the enteral nervous system. So how do these things affect diabetes? So what is known that these efferent signals, which were a result of the inflammatory process, are transmitted to the brain, and from there, various signals go on to the various organs in the body, like liver, adipose tissue, and the muscles, and these may change the glucose metabolism. So the glucose metabolism is affected by the changes in the gut microbiota. So what is the evidence of the microbiota link in the diabetes? Most of the evidence comes from the mice studies. So in germ-free mice, they're relatively resistant to diet-induced obesity. But if the microbiota of conventionally raised mice is transferred to these germ-free mice, they have an increased body fat content and insulin resistance. What is also recognized that high fat diet is associated with development of insulin resistance, and knockout of toll-like receptor 5 in mice could result in a diabetic phenotype. Now, this is mediated through alterations in the gut microbiota, increase in the intestinal inflammation, and we'll also talk about the GLP and GIP, that is the alteration in the incretin response. So this is what the data is from the mice studies. But from the human studies, what is recognized is that there is an alteration in the ratio of firmicutes and bacteroides, that the level of proteobacteria are increased in patients with type 2 diabetes. The butyrate producing organisms go down, and butyrate is actually very important chemical which could mediate the secretion of GLP, and we'll talk about GLP in one of the subsequent slides. Diabetics also have lower abundance of Akkermansia muciniphila, and this actually increases with butyrate supplementation and even with drugs like metformin. And eventually, in animal studies, this has been shown to improve glucose tolerance. So does modulation of microbiota help? So there is some data, actually a lot of studies from probiotics, which suggest that organisms like Lactobacillus, Bifidobacterium, Akkermansia could improve insulin resistance. But the effect size, unfortunately, is low, and so is the case also with the dietary fibers. But the overall effect size is very small and may not have therapeutic value. Now, what about fecal transplant? Well, while animal studies have shown changes or improvements in metabolic parameters with fecal transplantation, the evidence is anecdotal in human studies. But the fecal transplants could improve the microbial diversity, increase short-chain fatty acids, and this could affect the GLP production, resulting in satiety. It could improve the gut barrier function and reduce the intestinal permeability, thereby reducing endotoxemia and inflammation. And this may all result in improved glucose handling, reduced triglycerides, and weight loss. But the human reports, as I said, are very, very small and actually anecdotal. Now let us talk about the incretin effect. So this is the extra insulin which is produced with the oral glucose when compared to intravenous glucose. And this is mediated by two hormones, the GLP-1 and the GIP. But in diabetes, there is almost a complete loss of incretin effect. Why is GLP important? So when we eat and when the glucose reaches the small intestine, the K cells in the duodenum, the L cells in the distal small bowel and colon, there is they release GIP and GLP-1, and these have very important effects. They could slow the gastric emptying, and this will increase satiety. They also act on the pancreas to help secrete insulin and reduce the production of glucagon. And of course, they reduce appetite. So they have therapeutic efficacy for treatment of diabetes. And there are many agonists which are now available, including oral drugs also in pipeline. And then there are DPP-4 inhibitors. So this is the enzyme which metabolizes GLP-1. And these are now part of the therapeutic armamentarium for diabetes. These drugs have good efficacy. And the good thing is that they don't cause much of hypoglycemia and have additional benefit as far as weight loss is concerned. Now, very briefly about the duodenal bypass. So there are devices which prevent duodenal contact, and these have been shown to improve beta cell function and increase insulin sensitivity. So this has been used for a therapy which is now upcoming, that is duodenal mucosal resurfacing, where the duodenum beyond the ampulla is subjected to thermal ablations using a balloon. And after that, What is noted is that there is a reduction in HbA1c levels, improvement in weight, and improvement in insulin resistance. And this particular therapy has been shown in initial studies to have acceptable tolerability and sustained effect at 12 months. So this could be a possible therapy for diabetes mellitus in coming times. Now, to summarize, we have understood that gut-brain axis is a bidirectional communication. There is increasing recognition of the role of microbiota and alterations in microbiota. Gut-brain axis is now recognized to play a role in diabetes causation, and there are certain therapies which target this particular angle and have been found to be efficacious. But the role of microbiota modulation is investigational and could be useful in the future. Thank you for your attention.